A very good afternoon to one and all, respected colleagues, seniors, my dear oral pathologist friends. It gives me immense pride to stand before you today, not just as an oral pathologist, but as a representative of a specialty that is truly at the crossroads of dentistry and medicine, and for me at law also. By training, I am a dental surgeon, oral and maxillofacial pathologist, oral microbiologist, clinical biochemist, head and neck oncopathologist, and also a medical legal consultant and lawyer. These diverse journeys have given me one central mission to strengthen oral pathology as a recognized and indispensable pillar of healthcare. The focus of today's session is very clear. I'll be sharing with you insights across three interconnected domains: evidence based laboratory diagnostics in everyday dentistry, why tests are not just supportive but decisive in bridging the gap between provisional and definitive diagnosis, designing a compliant pathology lab and oral pathology consultancy or lab also for practical, ethical, and administrative aspects of setting up and running a pathology facility, legal, ethical, and regulatory essentials for oral pathology practice in India, because in today's world, knowledge of compliance and law is as critical as clinical acumen. I wish to emphasize that this presentation reflects my personal, academic, and professional experience. It is intended only for learning, awareness, and discussion, and does not represent the official stance of my regulatory body or institution. I dedicate this presentation of mine to Dr. Anita Borges, madam. And recently we lost her, so a tribute to her also. And I wish to quote that ma'am was such a good teacher that no one can forget the memories which or the teachings which ma'am has given us. So I always quote that you cannot transmit wisdom and insight to another person. The seed is already there. A good teacher touches the seed, allowing it to wake up, to sprout, and to grow. My guide, Dr. Usha ma'am, she has taught me a lot of things. And what I am today is because of her guidance, her teachings, and many more. Now, why I am showing this Kodak camera? Because there is a reason behind that. You have to see that Kodak was a big name in the industry of photography, but now it is not. Next, coming to the Nokia phone, this 3310, which was a very popular phone at a moment of time. So again, why I'm showing, now nobody is using this phone. A lot of cars which everybody has seen at some point of their time, or they would have owned also. But the reason why I'm showing is because these companies failed to change, and they they failed miserably, and it is in the public domain. So for learning purpose, these examples have been quoted that we have to change with time, and change will not come if we wait for some other person or some other time. We are the ones we have been waiting for. We are the change that we seek. Now coming to the core content, that why we need investigations, because case history and clinical examination, they reveal most of the information but not all clinically relevant data. The provisional diagnosis, when you have to convert it to definitive diagnosis, you need lab investigations. Lab investigations, They supplement rather than replace other methods for gathering information. And it's a known fact that with the help of lab investigations, some underlying systemic conditions which patient is not aware of, that can be identified in the dental practice for the first time. And yes, last but not the least, in today's world, a big medical legal safeguard. I would like to emphasize that oral pathology, as we all know, is not limited to histopathology slides alone. It's a vast discipline spanning hematology, microbiology, biochemistry, serology, molecular diagnostics, even forensics. And the reality is that dentists are the first professionals to suspect systemic disease in patients. And with proper laboratory integration, we can play a much larger role in early detection, referral, and prevention. So, my humble objective here will be to demonstrate how oral pathologists can bring evidence based diagnostics into daily practice, making dentistry safer and more scientific, and to highlight how, with legal and regulatory awareness, we can protect our profession, our patients, and ourselves. So, with that context, let us begin this journey into the fascinating interface of diagnostics, compliance, and law in oral pathology. Now, I have shared a picture in which it's a real case scenario, that a question which I often get, that can we sign oral pathology? Yes, we can sign oral pathology reports, but can we sign blood test reports as oral pathologist? So my answer sometimes is, can you tell me, is there any difference of blood which is flowing in the oral cavity and the rest of the body? Yes, we can sign because the blood is the same. It is not, it's a sarcasm that it's not some special dental blood made of saliva or toothpaste. It's a blood is a biofluid which flows everywhere. Now, the moral of the story is that if we are trained for 3 years in histopathology, hematology, microbiology, and so on the allied aspects as a part of our MDS curriculum, which is there available in the public domain, then what stops us from interpreting the same parameters we study daily? I feel it's the competency. We can diagnose anemias, leukemias, oral manifestations of systemic diseases, and histopathology. Blood tests are integral to our diagnostic decisions. So the question isn't really, can we sign? The real question is, why shouldn't we? So take home message, because the science is one, the blood is one, and the oral pathologist is very much a pathologist. Oral pathologist is a specialized pathologist. Now, there are different types of lab investigations. I would like to ponder upon, as I've already said, that why all these investigations are required. If any general practitioner is also there, so it will be useful for them, and even for the oral pathologist to highlight the importance of these investigations. Now, everybody is aware of the histopathology and cytopathology. So all the blood tests which are being done, they are not just hematology. We have divided into different sections like biochemistry, hematology, serology, microbiology, everybody knows, and clinical pathology, under which uh, urine, semen, stool, and other biofluids they come. And yes, molecular genetic testing is also a part of oral pathology. Now, a blood test can reveal so much about your body, but only if you can interpret the results, because your blood never lies. Now, under hematology, we have CBC, ESR, BTCT, and prothrombin time. So I've categorized in a way. First, I'll highlight the importance of each investigation and how it hampers the treatment. So those aspects like WBC component, RBC, and platelet, all three constitute CBC, and under which we have total count, which is TLC. The other one is the differential count. RBC, we have the count, we have hemoglobin, we have hematocrit, and there are different indices like MCV, MCH, MCHC, and RDW. And every parameter has a special meaning, which is very important for us as pathologists to know, because From CBC, I have diagnosed almost 200 cases of beta thalassemia minor. So it's such a big thing which you can guide to your patient to overcome any kind of future implications. Then coming to platelet, you have platelet count, MPV, PDW, PLCC, and PLCR. That means platelet distribution width, mean platelet volume, platelet large cell count, and platelet large cell ratio. It is a common CBC report which I signed, so I have just shared uh, the format how it is. Now coming to the disease pattern like anemia. Anemia is very common in India. 53% women are anemic, and 50% of pregnant women are anemic. So in total, 53% and 50% of pregnant women. And yes, there is a mission, Anemia Mukt Bharat, by National Health Mission. Now, this is a treatment planning triad. One side is the disease, the other side is the lab investigation, and the other side is the dental procedure or treatment. If a patient is anemic, iron or vitamin B12 deficiency, so the investigations required are CBC, iron profile, B12, folic acid. These are mandatory because if you directly jump and the patient is severely anemic and any bleeding happens, so it's going to impact the treatment outcome which you are going to do. It may seem very hypothetical, but as a medical legal consultant, I must tell you that there are many cases in which such things have happened. Now, role of dentists in screening anemia. So they should understand the different manifestations of anemia, in which history taking lab investigation is very important. And then you can refer to physician for treatment. You have to correlate the clinical presentation and blood investigations to come to a final diagnosis. Yes, there are leukemias also, and manifestations are there. We know that there are two types, the broad categories, acute and chronic. And under acute, we have ALL and AML. The other one we have is CLL and CML. So the tests for leukemia is also CBC, is very much important. Then the gold standard is peripheral blood smear. After that, for categorization, we need flow cytometry, bone marrow examination, and different molecular tests. So CBC is very important to diagnose anemias as well as the leukemias. Coming to serology part. Under serology, for dental practitioners, we have triple H. That is HIV, hepatitis B, surface antigen, and anti-HCV. All these are card-based, so done either by agglutination method or ELISA. And this should be carried out before any surgical procedure. So this is a HIV tried-out card. You can see a control is there, and there's a set of a protocol, a procedure is there, and when you do, so you can get to know. And I must tell you, in some areas of India, hepatitis B is endemic, and there are many areas which constitutes approximately 40%. Maybe the region where I practice, I get a lot of such cases. So this is hepatitis B, which is again a positive one, and we always say reactive for the word, but for better understanding, I have placed it as positive to make everyone aware. So it is called as reactivity, and then afterwards when we confirm it, so we confirm by ELISA, and that will be a positive. So HCV tried out, again the same procedure, everything same, these are being used. So these are common tests and which can be incorporated in their practice, and yes, we can do that. Coming to syphilis, again syphilis is now no more a old kind of disease. It's very important in many cases in teenagers and youngsters. I can see the tests which are being done is PDRL, and RPR. But nowadays we have rapid antigen tests in which IgG and IgM antibodies are there. And IgG antibodies, they are more specific and tend to last longer. So these are the manifestations. The manifestations will be chancre and any kind of ulcerative or red or white ulcerations you see in the oral cavity. Please consider syphilis as one of your differential diagnosis. It's a recent case in which the patient came reactive for syphilis, and when I did the oral examination, the other way around, not the patient came for other investigation, for investigations were done for any surgical treatment. I think the surgeon would have had some doubt, but when I did the oral examination, I could find that there are painful ulcers in the oral cavity, and the history pertaining to unprotected physical intimation was also there, and patient is 24-year-old person. So there are specific treponemial tests, that is TPHA, FTA, ABS, CLIA. So all these are the more specific test, because it is caused by syphilis is caused by Treponema pallidum. So TPHA is the commonly used one which we perform in the labs to confirm. Coming to CRP, everybody would have heard of this thing. CRP is C-reactive protein, and why it is called C-reactive? Because the reactivity of this protein was similar to the C polysaccharide chain of streptococcus, and that's why the name was called as C-reactive protein. And the level of CRP tells us that there is an inflammation in the body. So it is required for any kind of acute inflammatory conditions. If you're not getting, then also there is a reason for that. And yes, it's a useful indicator in SLE and rheumatoid arthritis, which have oral and maxillofacial manifestations. Now, coming to what is the difference between CRP and ESR? So they are both used as non-specific markers for inflammation. CRP is somewhat preferred as a serological marker for acute disease. It rises to 50 to 100 milligram per liter within 4 to 6 hours, and it doubles every 8 hours. And they will be markedly elevated and strongly associated with bacterial infections. While the ESR, in contrast to CRP, will rise within 24 to 48 hours at the onset of inflammation. And then it decreases slowly as inflammation resolves and can take weeks to normalize completely. Now, this CRP is like the experimental confirmation shows that another widely prevalent and preventable contributor to the burden of cardiovascular disease would be added to the options available to the clinicians and public health practitioners for the control of epidemic of cardiovascular disease. And the president of American Academy of Periodontology says that I foresee routine CRP testing in their dentist or periodontist office in the near future, because when CRP is raised, it is indicative of chronic periodontal disease. So by doing that test, we can get to know that what kind of inflammation is going on. Coming to RA factor, everybody knows what RA factor is. It is related to joints, and yes, it's a group of antibodies that attack the person's own tissue instead of targeting the invaders. And this high concentration of RA factor, it is suggestive of autoimmune system which is acting. Now, the diagnosis of TMJ involvement with rheumatoid arthritis is based on history, physical findings, radiographic findings, and lab tests. So we have a case pertaining to that, and it is confirmed with anti-CCP, that is anti-citrulline antibodies, and CRP for doubtful cases. This was a case in which the patient showed restricted mouth opening And you can see the CBCT image in which narrowing of the articular space and erosions on the superior head of the condyle. When CRP was done, it was highly raised, R factor was highly raised, even ESR was highly raised. So all these markers were elevated and they were indicative of rheumatoid arthritis affecting TMJ, and it was confirmed. Now coming to the biochemical investigations under which all the different systems that will be covered. We have blood sugar, thyroid function test, kidney function test, liver function test, and lipid profile. And why PTI? Because I have considered under which the cardiovascular system. So we'll flip through all those things and get to know that why all these investigations are necessary. You know, diabetes is a growing epidemic in India. 44.2% increase in prevalence from 2019 to 2023, and national diabetes prevalence is 11.4%, and 136 million people with pre-diabetes. So all these patients, when they come to a dental office, so you never know, they may have diabetes. So these are the commonly done tests: fasting blood glucose, postprandial, random, and glycated, which is HbA1c. So HbA1c is more specific test. It has some limitations, like in case of hemoglobinopathies, but it will tell you the average blood sugar level over the past 90 days. And one should maintain it less than 7 for therapeutic range, otherwise it is 6.4. Now coming to the treatment planning aspect, if the patient has diabetes, you have to get sugar and HbA1c done. Sugar might be misnomer because random blood sugar will be um, like it can be raised or decreased because sugar changes every 15 minutes, and the different aspects which are being done, the different treatments, so it all are affected because of blood sugar levels. Now, dental extraction in diabetes individuals, fasting should be 180 milligram per deciliter as a cutoff. Random should be 234, and tightly controlled diabetic, if below 70 milligram per deciliter, they are susceptible to hypoglycemia. I think you can take screenshot of this. It is by Gath et al. Dental setting as diabetes screening opportunity. Yes, it's an ideal platform, and everybody knows that the sixth or the fifth complication of diabetes is periodontitis. So it's an ideal platform for diabetes screening and early intervention. So incorporating HbA1c testing into dental visits will definitely help us identify undiagnosed and poorly controlled diabetes. And this proactive approach strengthens the collaboration between dental and medical professionals to help promote the comprehensive patient-centered care and improve health outcomes. Next is thyroid. Again, a lot of people in India have this disorder. As per 2024, 42 million people in India. Now, under thyroid testing, we have TSH, T3, T4, including free thyroid also, FT3 and FT4. If you see the treatment planning triad, yes, if they have any disease, thyroid profile needs to be done. Now, why, how it's going to affect the treatment part, I'll explain. So, patients who are hyperthyroid, they are generally on the treatment of propyl thiouracil, and under which the potential uh, uh, side effect is agranulocytosis and bleeding. So CBC and PTI are must for that. In case of hypothyroid, yes, they will have increased triglyceride levels. And remember, increased triglyceride or cholesterol levels, they hamper osseointegration in implant cases. And these patients have chances of atrial fibrillation more. So INR also need to be done if they are taking any kind of anticoagulant therapy. Very common, chronic kidney disease. 5 lakh Indians are believed to be in treatment with dialysis. And CKD is a worldwide public health problem. Now, the patients who have kidney diseases, they have prolonged bleeding, high blood pressure, high triglyceride levels, and infection tendency. This is a sample report under which urea, creatinine, calcium, blood urea nitrogen, BUN, creatinine ratio, and electrolytes, sodium, potassium, and ionic calcium. It is generally given by me. You may find some kind of changes depending on the variation in the lab. Now, the patients who are on dialysis or renal failure, you have to get CBC, coagulation tests, and serological tests, and then only consider dental implant. Otherwise, the outcome of implant will not be that great. So, a proper investigation of the disease is must. If we see the oral symptoms, you will find that 90% of renal disease patients will have oral symptoms. The most common is halitosis. You can find out a specific kind of bad breath from renal disease patients. And the other things which include is early tooth loss, periodontitis, xerostomia, and gingival bleeding. Now, the preoperative blood tests which need to be done is parathyroid hormone, CBC, bleeding count, clotting time, and PTI INR. FGF23 is 23 is not required. Yes, vitamin D is required because patients have renal osteodystrophy. Now, all these patients, those who are on dialysis, the chances of getting the serological diseases like not the viral diseases will be more. So, getting a triple H is very important for them. Yes, they should be tested for tuberculosis. And for tuberculosis, we need FNAC, acid fast bacilli, MON2 test, ESR, IGRA, that is interferon gamma release assay, CBNAT. All these tests are required because these patients have low immunity and chances of contracting tuberculosis is high. This is a positive MON2 test. Why I showed? Because again, a similar kind of young patient with a kidney disease, and we could find a very exaggerated response of MON2. When you are considering antibiotic prophylaxis, so you should consult the patient's nephrologist based on the recent lab results. And these are the nephrotoxic drugs which are commonly used in dental practice, like NSAIDs, aminoglycosides, fluoroquinolones, antifungal, antivirals, proton pump inhibitors, that is pantoprazole, all statins, and ATT. Coming to liver diseases. So the main areas where we should inquire the patient with liver disease is any kind of hepatitis, history of jaundice, bleeding tendency, cirrhosis, any kind of tumors, transplants, or medications. So these are the things which should be elicited if any patient says that he has a liver disease. So it can be either due to drug toxicity, viral hepatitis, bleeding tendency. This is a sample report in which bilirubin will come, total bilirubin, then direct and indirect, SGOT, which is also AST, SGPT, ALT, the ratio of both the enzymes, alkaline phosphatase, total protein, albumin, globulin, and albumin globulin ratio. So this is again a case of viral hepatitis, hepatitis A, in which SGOT and SGPT are raised. Now, this was an interesting case of a 14-year-old patient in which you can see the the eyes of the patient, in which you can see that the sclera is yellowish. So The patient had a bilirubin level of 54. This was the first of the kind I have seen such so much, and over a period of time it got reduced. So patient was followed up and now he's normal. Was referred from a gastroenterologist. Then now coming to the treatment part for such cases, we have to get CBC done, PT-INR done, APTT and bleeding tendency test, and yes, LFT. Because if you do any kind of surgical intervention, the bleeding will not stop because of the liver disease, and again, the outcome of the treatment can be fatal. Now, how to manage the hemostatic alterations in cirrhotic or liver disease patients? The blood related is CBC and platelet count, and the coagulagram, liver related LFT, and the different enzymes and bilirubin levels. Coming to platelet, it should be, it is recommended that any patient whom you get a surgical dental procedure with a higher risk of bleeding, any kind of bone surgery, large flaps or multiple extraction, it should be more than 1 lakh per cubic millimeter of the blood. Normal count, is this parameter enough to confirm reduced bleeding time? The answer is no. Significance of immunization, yes, it is very important. Dental healthcare professionals, they are particularly at the risk of hepatitis B and C because of the blood and oral secretions of potentially infected individuals. So if we get any kind of accidental needle stick injury or with the sharp instruments, so the immunization is must. Again, it's the same for chronic liver disease. Yes, already being discussed. These are the hepatotoxic drugs, paracetamol, analgesics, the local anesthesia, the commonly used amoxicillin clavulanate, antibiotics, antivirals, carbamazepine, which is given for trigeminal neuralgia, statins. And for chronic hepatitis, yes, we need hepatitis B and C, and yes, there is a possibility that the patients who have hepatitis B and C, the co-infection with HIV also exists. Coming to cardiovascular diseases, again, everyone is aware that cardiovascular diseases, the prevalence is very high in India. Lot of heart attacks every year, and cardiac arrests are also increasing. So all these patients are generally on the anticoagulant therapy. So the deciding factor is INR. Now, what is INR? INR is the ratio of prothrombin time to mean prothrombin time. So it determines the anticoagulation status of the patient. And it is warranted to know that the INR value of a patient on anticoagulation therapy before a dental procedure. We should check the INR levels 72 hours prior to an invasive dental procedure. The therapeutic range is 2 to 3 in patients who are on warfarin, and it is most common anticoagulant used for prevention and treatment of thromboembolism for more than 50 years. Now, with the patients who have CVD, arrhythmias, or on anticoagulation therapy, any investigation which is required, the major is the PT and INR, international normalized ratio. Even if you are doing a scaling, please don't touch such cases without getting the test done. Comprehensive knowledge of the dentist about cardiac conditions is indispensable in imparting quality and safe dental care to this vulnerable cohort of dental patients. Coming to clinical oral microbiology, you know that why microbiological tests are required, because to conduct early risk assessment for developing oral diseases, to assist the diagnosis of oral diseases, and to retrieve auxiliary information for supporting the treatment, to follow and the treatment outcome. Now, why? Because of any kind of aggressive or refractive form of periodontitis, root canal infections, where a lot of First discharge is there, odontogenic abscesses, for selecting a suitable antibiotic following AST. The outcome will be much better if you subject the aspirate or the purulent material to culture and sensitivity. This is the report. Now coming to the last set of investigations which I will cover, that is FNAC biopsy. FNAC, everyone is aware, it's a simple, safe, rapid, reliable, painless, cost-effective, relatively non-invasive and easy procedure. So it is just like aspirating cells from a particular region of the body using a fine gauge needle. So a fine gauge needle, it is inserted. This is with the um, with a plunger, so that suction will be better. And FNAC plays an important role in diagnosis of extraoral and intraoral lesions, majorly presenting as lump or swelling. Yes, it is not that accurate, but for solid and cystic lesions, the diagnostic accuracy is 85%. Now, if you see my experience, the pathologies of head and neck region, they are very high in India. And prevalence of oral cancer, yes, everybody knows. Head and neck cancer constitutes 1/3 of global cancer, and oral cancer, it's the second most common cancer for both the genders. 30% of all malignancies in our country. The ability to control oral cancer and pre-cancer will depend on two cornerstones: prevention and early diagnosis. If you see the Globocan, so there is an increase of 57.5% from the year 2020. So this is my experience, which I am telling. If you see, 65% of cases are from head and neck pathologies. And under that, you can see the head constitutes 20%, parotid 3%, neck 29%, thyroid 13%, and breast and axilla the rest part. So 65% of the cases, and this is the archival records since 2016. And under that, what are the common lesions? Non-specific lymphadenitis, tuberculosis, which is necrotizing lymphadenitis, metastatic carcinomas, metastatic squamous cell carcinomas, epidermal inclusion cyst, colloid goiter, nodular goiter, pleomorphic adenoma, and others which are not that common, but yes, MEC and adenoid cystic carcinoma, lymphomas, lot of lymphomas are there. I'll go through a series of cases. It's a 17-year-old female patient presented with lymphadenopathy and with a major aphthous ulcer. When FNAC was done, lot of inflammatory infiltrate was there. So non-specific lymphadenitis or reactive lymphadenitis. 52-year-old male patient with a huge neck swelling, chronic smoker for past 40 years. And when we saw, the cytology was totally suggestive of major dysplastic changes, and it was ruled as metastatic squamous cell carcinoma. I will not go into the depth of the cytological part, but just to show that how this was done. 31-year-old female patient, parotid swelling, it was pleomorphic adenoma. 42-year-old female patient, lot of sinuses were there. She was diagnosed with necrotizing lymphadenitis, and tuberculosis was the final diagnosis. 64-year-old male patient, it was a aspirate, and again a lot of tumor cells were available. The squamous cells were highly dysplastic and metastatic squamous cell carcinoma. A pharyngeal swelling in 72-year-old female patient, along with the neck swelling, and the patient, I got to know through the attendants that she has a history of BD smoking from past 30 years. 56-year-old male patient with a swelling, post-auricular swelling, and it was a soft swelling. When the aspirate came, it was a very dirty, cheesy-like material. It was infected epidermal inclusion cyst. 35-year-old female patient, it was diagnosed with nodular goiter. You have to see the swellings which are in the neck region and they move during the deglutition. 27-year-old male patient with a huge swelling. It was abscess and the pus was aspirated, lot of neutrophilic infiltrate. And yes, he has a dental involvement of uh, the molar region. It was highly carious and probably has spread to this level also. Coming to biopsy, I won't go much into the detail angle of such things, but for the general practitioners, I want to highlight some of the things. Like they're generally exposed to oral lesions that require biopsy taking or referral to a specialist. So, which lesions are to be biopsied? Any lesion which presents for more than 2 weeks, any ulcerated lesion, posterolateral tongue lesions, particularly in the presence of concerning features including pain, paresthesia, raised borders, ulceration, such as dysphagia, weight loss, and bleeding. So it is a policy by American Academy of Oral and Maxillofacial Pathology. All tissues removed from the oral and maxillofacial region of human patients should be submitted to pathology lab for examination. Under this exemption is the clinically normally appearing extracted teeth, normal appearing extirpated dental pulp, normal appearing tissue, excess donor tissue. So these need not to be submitted. Otherwise, any oral lesion which is being, but I always suggest that the patient, even if the extracted teeth part is there, it should be submitted because you never know any kind of follicular tissue or periapical tissue which is being there with that. So there are reports indicating that dental practitioners may sometimes discard the pathological tissue taken from patients, including the diseased periapical tissue, contrary to the policy, or on excised tissue. Are biopsies really necessary? So I will consider these 5 aspects. One is the erythematous gingiva, desquamative gingivitis, mobile teeth, extraction, wound healing, impacted tooth, and white patch. So now you see all these 5 pictures and almost look the same. But remember one thing from the movie Drishyam, that visuals can be deceptive, in which one lesion is allergic mucositis, one is a pemphigoid, the other one is a lichen planus, and one is even squamous cell carcinoma. So the take-home message is oral lesions may appear similar clinically. Only histopathology can reveal its true nature. In some instances, the otherwise benign looking or inconsequential lesion ends up being malignant after histopathology. And believe me, this is true. If tooth mobility is present without any obvious periodontitis, do radiographic and histopathologic examination. This is the take home message. Submit the tissues that you get during extraction, whether it is periapical or follicular, for histopathology. Follicular tissue that you get along with impacted tooth has to be submitted for histopathological examination. Now, how to take biopsies? Preparation for biopsy, where to take, how much to take, and a simple method of taking biopsy. And why rebiopsy is advised? Because sometimes specimen is not taken from the representative area or the tissue specimen is inadequate. Now, when we see we have to prepare for biopsy, so we have to see that you should take a comprehensive medical history before, do a thorough radiographic and clinical examination, and do the interpretation, and then you go for the biopsy. When you plan, so you should have a bottle with 10% formalin in which 20 times the size of tissue it should come, and it should be a wide mouthed bottle, and you have to label it properly. Now, where to take biopsies from for potentially malignant disorders? Red area, the erythematous part. Ulcerative areas, the malignant ulcers, they will always be painless and should be taken from indurated area. Non-healing ulcers, you will find if they are from the lateral border of the tongue, yes, definitively the biopsy has to be taken from that. And in case of vesicobullous lesions, it should be taken 1 to 2 millimeters peri-lesional area and not from the lesional area, because all these things are going to affect our uh, histopathology. Why erythematous part for PMDs, potentially malignant disorders? Because otherwise the white area you will get a lot of keratosis, the keratin will be more. So we have to see that the area where the major pathology is going on. Now, how much depth? So a size of specimen should be at least 8 millimeter. You can take it with a punch, it's very easy. And for verrucous and highly keratinized lesions, more depth is required for biopsy. And please don't divide the tissue after surgery. Submit it to one pathologist at a time. If you are not satisfied with the report, you can always take second opinion. You can ask for blocks and slides, but it should be reported by a single pathologist. The tissue should not be divided, because the tissue which is being divided, the one bit may have the pathology, the other may not. It is not like blood that it will be the same. At the tissue level, things might be different. So general practitioners, they are primary oral healthcare providers, and they make up 80% of workforce. So they should be capable of doing incisional and excisional biopsies instead of referring patients to tertiary centers. Now, there was a study in which for lesions requiring biopsy, what do you do? So the general practitioners, they say that they call a specialist or they refer to a higher center. 65.66% of the general practitioners have said that. Now, what do you do after removal? Do you send for analysis? So 59.7% they send, and still a good number of clinicians, they don't send it for the analysis, or sometimes they send it and some have not responded. So again, a big chunk which is not submitting it for histopathology. Now coming to a major part of the session, and the second part, that is setting up a basic medical lab. Now, under which I would like to highlight that India's healthcare landscape is evolving with a trend towards consolidation and advanced technology. And as per the Journal of Pathology and Microbiology, the pathology lab sector in India has been growing at a CAGR rate of 11% due to increasing prevalence of diseases, rising awareness, and government initiatives. Now, what are the factors which one should consider to open up a solo lab? Type of lab you have envisaging, whether it's a basic, a medium, or a large level lab. What is the demand and population density? You have to see the proximity to hospitals and clinics. Check for competitors' presence. How many labs are there? How is the accessibility, infrastructure and visibility, the income level of locality, and local healthcare ecosystem. So this is a basic design of how it should be. There should be, even if you see a small lab, medium or large lab, one sample collection room, one consultation room, pathology room, equipment, power backup, and staff. Now, I will provide a checklist. In itself, establishing lab is a workshop and cannot be taught in just 1 hour lecture. So I will give a different things which will make you think, and you can consider these things before opening up the lab. So one thing is, you are a professional oral pathologist or you have a friend general pathologist. What is your type of expansion? Whether you are only thinking that you will open up a lab only on the direct patients, you have a lab with collection centers and a doctor tie-up, you have a lab in a hospital, you have to do a detailed market survey. You have to see the location, whether it's an established location or a new, residential versus commercial, and how is the visibility. This holds true for any kind of business or any kind of new venture. You have to see the proximity, how many hospitals are there in that proximity, how many clinics, how's the connectivity, whether a metro will go there, the commutation part is okay, the buses go there, you get autos for there, and how much is the commute time for you and the customers, and how is the supporting ecosystem, pharmacy or radiology. You have to see the target market size, the population area, the income level, as I've already discussed. Then if you see the competitor analysis, you have to see what type of labs are near to your place, what is the pathologist type, any lab particular type is there, or doctor tie up, or pricing. So these are the things which one should consider before materializing a pathology lab. Now coming to the building, whether it will be your own building, lease, or rented, you have to see the interior and exterior condition, your lab size. And yes, if you are starting with a small lab, you should always keep a scope for an upgradation. And the different utilities are, whether any uh, elevator is there, proper toilet should be there, power backup, water, drainage, and signboards. Now coming to the legality, if you are starting a new one, then you should make it a firm. That can be a partnership firm, a proprietor firm, a private limited, or LLP. And the statutory clearances is, one is the fire NOC, the biomedical waste approval, local municipality authority, yeah, sometimes in the Shops Act, and now Clinical Establishment Act. Yes, Dental Council registration is mandatory for oral pathologist lab. Now coming to the finance, whether it's a self-financed, you are going to sponsor it, and how you are going to do it, whether you will take a bank loan, you have to see all your aspects, family support. Then coming to the insurance part, which is very important, that your professional indemnity insurance should be there, life insurance, the AMC for all the equipments, fire, theft, and calamity. Staff planning, you can start with a receptionist. You yourself will be oral pathologist. Security person, okay, if you feel that it's not required for your area, yes, fine. Then phlebotomists, yeah, good phlebotomists are required, who are trained and have a good experience in blood sample collection, and qualified DML, is diploma in medical lab technology. Coming to IT infrastructure, yes, computers, internet, and lab information management software, which is LIMS, that should be there. Yes, others are optional. That depends on your lab, how you want to go about it. So, and all the tests you are not going to do by yourself. So you have to outsource the lab also. So you have to have a proper MOU with them. You can outsource the histopathology, the samples to them also, and get the slides and block. You can report. The other is different digital tools like WhatsApp automation, social media management. All these digital marketing tools are there, which will help you in market your app. So they include the website, YouTube channel, directory listings. You can have a mobile app for your lab, customer reviews and ratings. And yes, consultants which are required are You should, if you are planning for NABL, so that consultant is required. Yes, if it's a private limited or any big lab, then chartered accountant. And yes, lab managers, interior designers. Now the next thing is for the fresh graduates, I'm providing a checklist for oral pathology consultancy. In case, in my opinion, over a period of time, I have understood that if you do not have a workload of around 20 samples a day, then the option of setting up a histopathology lab will not be that viable. So if you have that much load per day, then I think one can start up the histopathology part. Otherwise, what you can do is you can start up a oral pathology consultancy, in which what you have to do is the legal thing which is required is you can register with the Udyam registration, which is MSME. You can make a proprietor firm. GST is not required for that. You can get a BMW authorization, in which you can collaborate with a prominent processing lab. You can cross the sample, you can give to them. They will get you the slide and block. What are the core infrastructure for that matter? It is required is the microscope, your laptop, printer, some storage cabinets for slides and blocks, Almira, and yes, I have already discussed about the MOU. So when you have that MOU, you can always tell that this authorization for biomedical waste is not required for consultancy, because you are just receiving the slides and blocks. So you are not generating biomedical waste, and whatever grossing you are doing, so just see that you should not discard the formalin, xylene, or any kind of hazardous chemicals just like that. That will be a crime. So be careful with the if you're handling such hazardous chemicals. So the consumables will be required. You should have biopsy requisition forms, containers for, like if you're doing LBC, for that containers will be there. Then you have to prepare 10% neutral buffered formalin. Okay, and you can put labels on that, and you can give it to you, the clinicians. Your stationery, which should be printed, letter pads, envelopes, receipt, your visiting cards, your brochures, your flex or display boards, report templates, and other are also required, which sometimes we do not know. So this is basically a checklist in which a small, even a pin is also mentioned. So these are the things you can take my number. I can provide later on, or you can click the screenshots. Operational, you should have a separate SIM card. Proper accessional number should be given. You should create a backup for the reports either in your cloud or external hard disk, and a proper transport system should be there for receiving slides and sending reports. Marketing outreach, again, it will be the same. You can have a Google business profile, a simple website, and social media preference. So the last is like word of mouth credibility will come on timely reporting, your clear diagnostic language, and value added correlation notes, that is clinical radiological correlation. Any kind of this legal thing which I want to tell, that all the grossing and processing include fixation, embedding, cutting, and disposal of biomedical waste is done at the processing lab. So you should have a MOU, official MOU with the processing lab. It should not be verbal, it should be documented when you are starting with that. And you have to register with Clinical Establishment Act. You can maintain the copy of that lab's biomedical waste authorization, which will protect you. And you can always mention that no biomedical waste is generated in the in your office or uh, in your consultancy premises. So biomedical rules, they will not be applicable because you have outsourced it, and registration is compulsory for Clinical Establishment Act. And when you are operating on slides and paraffin blocks, so you are legally safe. So scope is properly declared, you have the MOU, and documentation should be well maintained. These are the checklist which I can share with you all. You can see for establishing the lab. All the small details are also mentioned in that. So just to summarize, you can understand the landscape, what are the different qualifications requirements, how you have to register your lab, what are the cost and setting and scaling up. You have to choose the right location, choose right marketing and promotion strategies. Yes, challenges are there with established players, and challenges were there and will also be there. Yes, always keep yourself updated with the new things. You can always have a pathology lab software. Now, coming to the last part, that is the signatory and the legal aspect. Now, that includes a lot of things and a lot of statutes in which I'll briefly explain that why this is required. Now, why there is a lot of hue and cry when we talk about this lab reports, because the signing part, because lab reports should be signed to indicate the clinician that someone in the lab accepts the responsibility for the content of the report, and failure to sign is likely to produce loss of confidence in the lab. Lab reports should be subjected to some form of check before issue, and signature should be the evidence that such a check has been carried out. Checking requires medical as well as technical knowledge. So, signed reports give a validity and credibility. Now, why oral pathologists are empowered and why they can sign is because if you see the global burden of disease, as per WHO, caries, periodontal diseases, oral cancers, and oral manifestations, that they are the top four oral health conditions. And oral health condition which is affecting us, it will affect everybody. Now, these are the three statutory bodies. Now, NMC is into the action and DCI is there. And if we talk about the later part, so dentistry was, it's a medical subject. It is just that the qualification was made separately, and dentistry is the recognized branch under broad medical specialties as per NMC and also as per MCI. And oral pathology, everybody knows, is one of the recognized branches under dentistry as per law. So it's an overlapping branch of dentistry as well as pathology, and in turn a branch of modern scientific medicine. Now, what are the documental proof which empowers oral pathologists to sign clinical lab reports with specified investigations? Now, our DCI curriculum only says that an oral pathologist is expected to perform routine histopathological evaluation of specimens relating to oral and perioral tissues, and to carry out routine diagnostic procedures, which includes hematological, cytological, microbiological, immunological, and ultrastructural investigations. And they want to train a PG dental surgeon who, with higher competence in general and special pathology. These are the references you can take. Routine hematological tests and clinical significance is being mentioned under page number 19 as per MDS regulations. Again, hematology, microbiology, and urine analysis. If you see at page number 94, it is mentioned for the exam part that HB, BTCT, TLC, DLC, ESR, smear preparation, and histopathology slide discussion. Even in the BDS internship 2011, blood, urine, and sputum examination, exfoliative cytology smear studies, biopsy lab procedure, and reporting. So these are the subjects which are being mentioned as a course content as per DCI revised MDS course regulations 2007 as well as 17, and which is published by the Gazette of India Extraordinary Part 3 Section 4. And whatever is published in the Gazette of India is law. So an oral pathologist should have adequate training and competency to report the following tests, which includes all the things: hematology, serology, biochemistry, microbiology, and but all these are routine. If any kind of more specialized aspect is required, and yes, for histopathology and cytopathology, only oral and perioral tissues. Yes, these are also the things which sometimes says that a dental surgeon can not claim to be a specialist unless he has a special qualification. So we have a special qualification and we can practice that specialty. It is as per 2014 Dentist Code of Ethics. And as per one of the RTIs to Dental Council of India, dentists can perform the procedures, whatever is present in the syllabus or course curriculum of MDS oral pathology and microbiology. I have filed a lot of RTIs to government dental colleges as well as private dental colleges pan India, and these are the results, and under which all these things are being carried out at the different dental institutions pan India. So you can see all the histopathology of oral and maxillofacial region. FNACs are also done. Not all colleges, but some it is being done. But if one or two are also they can do, then others also can do. CBC, ESR, BTCT, clinical pathology, urine and sputum examination, even biochemistry, blood sugar, lipid profile, and we know that it is required for before any kind of major surgical procedure of uh, maxillofacial region. Triple H by rapid card method. Basic microbiology, even some have bacteria and fungal isolation using culture techniques. And molecular pathology, some institutions have PCR based investigations. And yes, ultrastructural investigations, not this as per the analysis. Now, qualified oral pathologists holding MDS degree, they are already signing lab reports from past many years in the qualifications. And some have mentioned that the minimum qualification of any teaching faculty member is MDS oral pathology and microbiology. And if we compare the MDS oral pathology curriculum with the MD curriculum, the major difference lies in the histopathology part and some aspects of hematology, which can be learned by all of us. And now the thing is, like, DCI and law, they have allowed BDS or MDS degree holders to sign age estimation death certificate. So why not lab reports? So these are the different pleas which I am giving you. And yes, we are trained in general and special pathology, and we can sign reports. Now, as per the Honorable Madras High Court judgment in 2023, it said clearly that BDS is a system of medicine dealing with dentistry. It is a recognized modern system also. And this fact is acknowledged by Royal College of Pathologists, UK. Yes, oral pathology is a branch of medicine or dentistry and pathology, like other branches of pathology, as neuropathology, nephropathology, dermatopathology, oncopathology. So same wise, oral pathology is the branch. Now coming to the different meetings at the Government of India level, at Ministry of Health and Family Welfare, the first representation sent by me in 2017, then 18. So it was mentioned that signing of reports by those holding MDS qualification in oral pathology, it can be allowed. So the primary evidences which are being used as per the Indian Evidence Act, which is now Bharatiya Sakshya Adhiniyam, so are DCI MDS regulations, DCI BDS regulations, Code of Ethics, Minutes of Meeting 2017-18, and now after that 2023 and 24 also. An NABL approval letter of 2018, yeah, it had some discrepancies, but it has also allowed. The secondary evidences are the RTI replies, which I have collected over a period of long time. Now it is 19, I have to update it. Now it is still 2024. So a good amount of RTI databases with me. And Even my lab, to Hanamangalam Diagnostics, is NABL accredited. And when I can sign as oral pathologist, why not all oral pathologists, all my peers, all my friends? Just to conclude, I'll just tell one story which I get a lot of times, and with a context I would like to explain that, sir, we are not getting jobs in the diagnostic centers and all like that. So I'll give you a story. Is The name is fictional. Dr. Rajesh is a young dental surgeon, entered a reputed dental clinic looking for a job. So he says, and he declared that I will join your clinic, but ma'am, I have conditions. I will do only composite restorations in anterior teeth. I will not do molars, extractions, prosthetics, or anything else because I am an expert in this one thing. So, clinical honor, we need a dentist who can manage all kinds of cases, not someone who limits themselves. So, patients will not come only for what you prefer to do. The clinic owner smiled but politely declined. So, Dr. Rajesh walked away disappointed. Now apply this scenario parallelly in oral pathology. A similar situation is seen with many oral pathologists when they approach a diagnostic center. They often say, I know only histopathology and that too oral histopathology, mainly biopsies from oral and maxillofacial region. At most, I can attempt FNACs of head and neck swellings. Very few can tell. But diagnostic centers, they survive and thrive on hematology, biochemistry, serology, and all other blood and urine investigations, the daily bread and butter of any lab. Limiting oneself only to oral pathology makes the pathologist less attractive to the employer. So, if you take it a positive example of another fictional name, Dr. Meera's journey, she's an oral pathologist from Delhi. She finished her MDs. She too focused only on oral biopsies, but she quickly realized that most labs earn 70 to 80% of their revenue from routine investigations like CBC, liver function tests, thyroid panels, lipid profiles, urine analysis, infection markers like viral markers, and FNEC. So instead of restricting herself, she enrolled in short term courses in clinical biochemistry, hematology, lab management, and she got trained under senior pathologist. She asked in the evening time, she used to go to a prominent diagnostic center, and there she learned the basics of FNC. So within 2 years, she set up her own lab, combining oral histopathology with general pathology with routine investigations. And now she says, I am a lab owner. So you see, Dr. Meera not only receives biopsy referrals from dentists and oral surgeons, but also handles general physician referrals, preventive health checkups, and corporate health packages. Her lab has grown, she has employed staff, and she is financially secure because she expanded her domain knowledge. So, dental surgeon says, hello, Dr. Meera, I have sent a biopsy specimen for histopathological analysis. And physician says, Dr. Meera, I have sent my patient for CBC and urine routine. The moral of the story is just as Dr. Rajesh lost an opportunity because he limited himself, many oral pathologists risk the same by restricting their scope. But the story of Dr. Meera proves that when oral pathologists broaden their skills into hematology, biochemistry, serology, clinical pathology, they can transform to complete diagnosticians indispensable to healthcare centers. The take home message is survival and success in today's competitive world demand learning beyond oral histopathology. Oral pathologists must adapt, upgrade, and embrace allied diagnostic sciences to be recognized, respected, and rewarded. So this is what is Atmanirbhar oral pathologist. Instead of job seekers, why can't we become job providers? So the conclusion is overlapping scope of practice is reality in rapidly changing healthcare environment. No single healthcare professional can claim an exclusive role in diagnosis and treatment. Competency is someone's subjective dedication and ability, and not on qualifications only. It is rightly said survival of the fittest. So the competent people will survive. Oral pathologists are those qualified healthcare lab professionals who are authorized to sign lab reports, and they can play a major and important role in medical diagnostic laboratory. My sincere gratitude and acknowledgement to my teachers and the entire oral pathology community and my dear oral pathology subject. I owe to you. OPMA, a platform, and all the organizers for giving me the opportunity to present my views in this conference. I'm thankful to all the governing body members and all POPMA members for having trust in me, my patients because they are also my teachers, my parents and my family because I have divided my attention to oral pathology, and it is because of their sacrifices that they have given me that time so that I can go ahead and lead in this time for oral pathology. My wife, Dr. Jyotsna, and my son, because I have taken their time and diverted it to oral pathology. Last but not the least, with the grace of God, and thank you, Almighty. Now, to finish, I would like to say that mindset is everything, and no one can destroy iron, but its own rust can. Likewise, none can destroy a person, but his own mindset can. Believe in yourself, your abilities, and your own potential. Never let self doubt hold you captive. You are worthy of all that you dream of and hope for. This is my team at Tohana Mangalam Diagnostics. I am the primary NABL approved authorized signatory, and it is registered with Clinical Establishment Act, and it's the only first and only accredited medical lab in district Fatehabad. And I'm proud that I am the oral pathologist who is being assigned with that. Another setup is the Center for Oral Pathology and Maxillofacial Diagnostics. It's a specialized center only for clinical and histopathological evaluations of the pathologies of head and neck region. At the end, thank you everyone, and I must say with proud that oral pathology mera karma, oral pathology mera dharma, and oral pathology mera abhiman hai. Thank you so much. I'm open for any kind of questions.